all of you. We're here for a previous presentation I did. I think it was back in July now already. And that was a little bit more of a discussion-based presentation. This one is going to be more like a webinar. It's just going to be me talking at you. And I do apologize for that, but that's kind of the nature of the information. So just quickly, I'll go through the objectives and the agenda for today. And please, at any point, if you want to stop me, ask a question, make a comment, I'm totally fine with that. Unmute yourself, feel free to do that. And then I will have some time at the end for you guys to ask any questions that you might have at the end of the presentation as well. So high level, the objectives for today is to understand the steps and the considerations to be made in starting a telemedicine program, understanding the legal and regulatory requirements for telemedicine, and then general telemedicine reimbursement rules. So I'll do a basic overview of telehealth just to give you some foundational knowledge and make sure that we're all on the same page with terminology. And then I'll go through some general steps of starting a telemedicine program. And those will be focused on if you are in a healthcare clinic or a hospital or even a private practice and you want to start a telemedicine program, where do you start? What are the steps you need to take? What are the things you need to consider? And all of that information will be general, and the reimbursement and regulatory rules that are addressed in that section are the standard rules under normal circumstances. So then I'll follow up that with the impact of COVID-19 on telemedicine, including the regulatory and reimbursement changes that are in effect due to the public health emergency. And then I'll share some resources with you where you can find additional information if you need, and then we'll finish with a question and answer session if you guys have any questions. So baseline terminology for telehealth versus telemedicine, these terms are often used interchangeably. I apologize, there's an auto transition on that apparently. The telehealth and telemedicine are used interchangeably, but the way that we are going to utilize this terminology is that telehealth is kind of a broader term, meaning the utilization of digital technology in health and medical care and health education and public health, anything related to health that you're using technology. So it's a much broader term versus telemedicine is more that direct to consumer, direct to patient care. And so here are our definitions. And then within telemedicine, so when you're providing clinical care from a distance, when we use the term distant site, that means the site where the physician or the practitioner who's delivering the care, that's where they are located, is the distant site. And the originating site is wherever the patient is at the time that telemedicine is being delivered. So payers consider the patient's location as the location where the service is originating, and that's where the service is taking place. And it's important to try to think about telemedicine as a tool to deliver care, not as a type of care. So that's an important distinction, because sometimes I'll get asked the question, well, how much will I get paid for telemedicine? And telemedicine itself is not care that you're delivering. It's a tool that you're using to deliver care. And that's also something to keep in mind related to the regulatory world around, the standard of care and documentation and all of those things. So there are a lot of different types of telehealth. I think the one that people kind of generally think about is that live audio visual. So that's that two-way connection between the patient and a provider via a video conference software like Zoom functions. And there are certain payers, Medicare included, that define telehealth that way. And everything else that is not a two-way audiovisual connection, they do not consider that telehealth. They define it as a virtual connection or some other way, but they don't call it telehealth. You can have an audio-only connection. store and forward, where a provider will send like a scan or a photo to a specialist for a consult. Remote patient monitoring, where you monitor vital signs. The patient will have a device that's monitoring the vital signs and sending the information to a provider. And then Medicare has, within their reimbursement structure, these three types of what we would call in a broader scope telehealth. But again, Medicare does not consider these to be telehealth per their regulatory guidelines. So virtual check-ins are really intended to be like a quick phone call with your provider to say, hey, I have this rash, or I have this cough, or I have whatever. You may send them a picture, and the provider is determining if a visit is needed. So it's a 5, 10 minute, 15-minute phone call. The e-visits are a little bit broader than that. That's through the patient portal, where the patient will initiate contact with the doctor, and it requires a little bit more of the provider. There's a back and forth conversation, the provider's evaluating, maybe adjusting the care plan, and actually providing treatment through communication in the patient portal. And then chronic care management is non-face-to-face services provided to patients who have 2 or more chronic conditions that are expected to last at least 12 months or until the death of the patient if you have a terminally ill patient. So those are our definitions of our different types of telehealth delivery. So getting into starting a telehealth program. So high level, these are kind of the steps. You'll form a team, make a plan, make sure that you understand all of the legal and regulatory considerations, get all of those lined up, get connected with your technology, inform your patients that it exists, obviously conduct your visits, and then you'll bill and reimburse for the services. So the first step is when you're forming a team, you want to make sure that you're including all of the stakeholders. It needs to be a multidisciplinary team. Providers, the nursing staff, other clinical staff, your front office staff, nursing, medical assistants, anyone who may at any point be involved in that visit. Your compliance and regulatory team, your billing and coding, your registration team, administrative team, finance team, and obviously the IT staff are going to be vital people to have on this team. And you want to pull them in as early as possible and start having these conversations about what you want to do, what you can do. Determine what need actually needs to be met. So you'll want to consider the needs in the community. A lot of facilities do a community needs assessment. Well, they'll determine what are the medical needs in that community. Some facilities are required to do those. And so utilize that information if you have it. And, we talked about this last time, what are the patient's barriers? So there may be a need in the community that you want to address that, the patient has barriers that you can overcome using telemedicine, or on the other hand, there may be barriers that the patients have that's going to make it difficult for them to utilize telehealth for the service that you're trying to provide. So those are all things that you need to consider. And those will be important things to understand and to know when you're determining everything else that you're doing. So when you move into determining what your software and your equipment needs are, you need to know what service you're actually trying to provide. Because if you're trying to provide mental health services, you need very different equipment than if you're trying to provide dermatology or ENT or something else that requires like a peripheral, a hands-on service. So you'll need different equipment, you'll need different software and those sorts of things. And then again, you'll need to know what the organizational barriers are, both financial and technological and otherwise, and what the patient's barriers are. You don't want to set up and choose software and equipment to utilize that your patients are not going to be able to use for one reason or another, or are not going to be compatible with the software and the equipment you already have at your facility. And then when you're beginning to plan for reimbursement, you'll need to familiarize yourself with payment and policy. So that includes all the legal and regulatory and the billing requirements. So what are all the things that you have to make sure are in place before you can do a visit? And we'll talk about some of those in more detail. And then what are the billing requirements for all of your payers? And it's a good idea to reach out to whoever's your biggest payer or your highest payer, just to make sure that the thing you want to do is actually covered by that payer, and making sure that the reimbursement is where you expect it to be and that you understand exactly how they want you to bill. It's a good idea to talk to other providers, especially ones that you know are doing similar services, and talk about what their challenges were, what their successes were, what are their best practices and their lessons learned. And then make sure that telehealth is covered in all of your managed care contracts. It should be these days, but it's always good to just double check those things. And then make sure that your billers and your coders have all the information that they need to bill correctly. These rules do sometimes change, especially right now during COVID with everything. And then as new regulations come out every year, the rules may tweak and the payers may change their policies. And so they may have a specific modifier that's added or removed, or the meaning has changed. And so you want to make sure that the billers and coders are kept up to date on that information. And then develop your policies, your procedures for how the visits are going to work. How far in advance are you going to contact the patients? Are you going to text them? Are you going to email them? Are you mailing them stuff ahead of time? Are you emailing them things ahead of time? Who's reaching out? Who's making the connection? Where's your provider going to physically be? Are you going to do telehealth visits only on Tuesdays during these times, whenever the patient wants? All of those things. You need to think about your actual processes and your policies and put the policies and procedures down in writing, so that all of your stakeholders know what the expectation is. And then have contingency plans and write those down as well. So you will have a provider who can't figure out how to get the camera to work, or a patient who, is trying to take their call in a loud, busy restaurant or something like that. And so what are your contingency plans for all of these things that can go wrong? And what are the steps that the provider and the staff need to take when those things happen? And the next step, providing education and getting buy-in, is a really important step. Based on a lot of the kind of anecdotal evidence and presentations that I've heard over the last several months, that there's a lot of providers who have increased telehealth utilization in the past few months with COVID. And they said, a lot of their physicians and their providers were very hesitant to use telehealth in the beginning. And getting that buy-in and providing them as much education and prep as possible ahead of time really helped to make them more comfortable and get them to try it and to use it. And once they used it, they liked it, but they needed that kind of hand-holding at the beginning. Train them on the software and the hardware, and what to do before the visit, during the visit, after the visit, all of the documents. Teach them about virtual etiquette, looking at the camera versus like looking down. Things like you will need to tell the patient what you're doing more. You'll have to use your words more because you're not able to physically touch the patient. So if you're looking down to say chart in the medical record, you need to tell the patient that that's what you're doing, because in an office setting, they can see you do that. They can see that you're documenting in the medical record, but in a virtual visit, that may look like you're distracted. So things like that they need to be trained on. And then how to actually do the virtual exam for whatever it is that, whatever service you may be providing. And there's lots of webinars and trainings and things out there for specific types of exams. And so how to get the patient more involved and how to collect that data when you're not physically in the room with the patient. And I've heard of some facilities actually conducting and recording mock sessions that they've provided to the physicians, and they found those very helpful. And then another thing, the providers, they don't like to learn about rules and regs, but they need to know what they are so that they know what they have to do in order for the visit to be billable and viable. And then you want to make sure that you're evaluating your program. Almost every single presenter that I've heard that has started telemedicine in the last few months has said, just jump in, like do all your things, prep as much as you can, but at some point you just have to jump in and make some mistakes and see how it goes. And then you fix it. But you don't know what's going wrong unless you're evaluating it. So make sure that you're planning ahead of time, what you're going to measure, how you're going to measure, and collecting that data so you can learn and continue to improve. So legal and regulatory considerations. So I do want to point out a couple caveats. First is that some of the regulations that I outline in this section are specific to Louisiana. And so if you are trying to practice in another state, you move to another state, some of these rules may be different. So you'll need to make sure that you are checking the rules in the state where the patient is located. Because again, the rules are based on where the patient is. And then, as I mentioned in the beginning, all of these rules are under normal circumstances, and some of these may be different or waived during the public health emergency. So again, as I mentioned earlier, telemedicine is a different modality of delivering care, but it's not intended to replace in-person care, but used to optimize resources. And so the physicians and healthcare providers are held to the same standard of care as if they're providing face-to-face in-person care. And also an important thing to note is that there are some federal laws and then there's some state laws, but the federal laws and regs don't always supersede the state laws and regulations. Usually whichever rule is the strictest, if there's a conflict between them, the stricter rule is the one that must be followed. So licensing is an important regulation to be aware of. So again, the licensing regulations must be followed wherever the patient is located. So the provider who's providing services needs to be licensed in the state where the patient is. So each state has their own laws and regulations around licensing, and they're typically enforced by the state medical board. A lot of states have, there are 9 states that have a specific telehealth license, and Louisiana is one of those. So an out-of-state provider can acquire a telehealth license just to do telehealth services with patients in Louisiana without having to have a brick and mortar location in the state. This is a citation of the regulation that says that providers have to use the same standard of care when delivering telehealth services as they would if the patient was in person. And the expectation here is that if a provider is in a telemedicine visit and they feel at any point that the service is not meeting a standard of care and they're not delivering quality care to that patient, they're expected to end that virtual visit and refer the patient to inpatient care either at their office or at an emergency department or an urgent care clinic. But they're expected, the burden is on the provider to ensure that the same standard of care is met and that that patient is receiving quality health care. Informed consent, there's always a consent for treatment in general, regardless of where that visit takes place and how it takes place. But Louisiana also has a specific telehealth consent requirement. And that states that in addition to your general treatment consent, patients must also be made aware and consent to the risks of telemedicine that are specific to telemedicine. So that includes delays, equipment failures, security breaches, those sorts of things. And they need to be provided with sufficient information to address and explain the limitations of technology. And so they need to know that, you know, there's a risk that the call may drop, or there may be a lag, or, a lower quality image, all of those things. And information on how to overcome those barriers and what's the plan if the call drops, if we lose the video, that needs to be explained to them, how that works. So ideally you would get that consent written with signature, or you can get it an electronic affirmation. You can send them an electronic form and they click, yes, I agree. But at the very least, that needs to be explained to the patient orally when the visit happens, and then the provider needs to document it in the medical record that very specific consent happened. And then there are certain circumstances where there may be a specific or additional consent requirement for certain services that's required by the payer. So for example, some of the like the chronic care management, remote patient monitoring for Medicare requires like an annual consent that has to be done before the visit takes place. HIPAA applies to telehealth encounters just like in-person encounters. And so all of the privacy and security safeguards must be in place. It's a little bit more complicated because it's virtual and there's distance, and you have that risk of hacking and those sorts of things. So you need to make sure that you are utilizing a HIPAA compliant software, and that risk assessments are performed to assess security risks. And then the provider, you still have to provide the HIPAA information that you would provide to a patient in an in-person visit. And then make a good faith effort to try to get a written acknowledgement. So when a patient comes in the office, you hand them the HIPAA information and they sign saying, yes, I received this. And so you need to make a good faith effort to try to get some sort of acknowledgement from the patient that they received that information. And then when you're conducting a visit, because you don't have control over the environment where the patient is located, in a normal office setting where you can close the door and you can make sure that there's privacy, you need to explain to the patient and encourage the patient that they want to take this visit in a private place. Don't take it in in a restaurant or in a store or something like that. If you have family members in the room, you might want to ask them to leave, that sort of thing. And if there's an instance where you would have a patient in your physical office and they have like their parent or their spouse or their child with them, and in an in-person visit, you would ask that other person to leave the room to have a specific, sensitive conversation or do some sort of exam, anything like that. If you would ask that person to leave in an in-person visit, then you need to ask that person to leave in a virtual visit, and then ask the patient to turn their camera and do a 360 of the room to verify that that person has left and that patient is now alone, so you can conduct that secure visit and ensure that the patient has privacy. And then don't record the sessions. There's not, as far as I'm aware, a specific rule against recording it. It's just really don't recommend it. You wouldn't record an in-person visit. So it's just not typically a good idea to record a telehealth visit, because then you just add additional, you add cost to having to store that information, and also you add additional security risks. There are online prescribing limitations. So in Louisiana, physicians cannot order, dispense, or administer controlled substances via telemedicine unless they've had an in-person visit with the patient within the last year, or if the patient is in a facility, such as a hospital, for example, where they have a DEA license and they can administer that drug to the patient, then if the provider has a license to practice and can normally prescribe that, and the patient can be administered that drug by that DEA facility, then they can order it that way. So again, like if you have a patient in an inpatient setting, a distant provider can order a medication to be administered by the hospital. In that same situation, if the patient is located in the hospital, the provider at that distance site needs to be credentialed and privileged at that facility to be able to provide virtual care. There is this flexibility called privilege by proxy for the Joint Commission allows smaller hospitals to, under certain circumstances, to accept the credentialing of a larger hospital. So the small rural hospital can say, you know, we don't have the means to credential and privilege at all of these distance site providers coming in via telehealth, but there's a larger hospital that has already done their research on this person, and so we're going to accept their approval of this person and allow them to see our patients. But there's specific requirements around that. One thing that's sometimes overlooked is malpractice insurance. When you're doing a telehealth visit, you kind of open up to a little bit of a different vulnerability in terms of malpractice suits. And so some of the examples are listed here of when a suit has been brought against a provider for a visit done via telehealth. And so the thing that you want to make sure if you are a provider doing telemedicine is that the insurance, your malpractice insurance, specifically covers the telemedicine visit and not only face-to-face encounters. So that's a question you want to make sure that you ask. And then you want to make sure that obviously don't commit any fraud or abuse through telemedicine. That's pretty much a given. But there's a risk of kind of an accidental issue with the Stark and anti-kickback law. And so if you're not familiar with those laws, basically the gist of them is to prevent, for example, a hospital of giving a kickback or an incentive to a provider to refer them patients. And so where some facilities get in trouble with this is they have a provider that they want to work with, and they may provide telemedicine equipment to that provider. But if you don't paper it up correctly and go through your legal team, then you are providing free technology to a provider, which can be viewed as an incentive to send you patients. So you really want to make sure that it cannot be construed as incentive for referring patients. So that would be something you'd want to discuss with your legal team if you are planning to give equipment to anyone that is not employed by your facility. So once you have all your policies in place, you know all your legal things, all your regulatory rules, you've got all of that in place, and you know what equipment you need, you'll need to get connected. So the bare minimum connectivity bandwidth that you'll need to do a video visit is the 512 kilobytes per second. That's going to give you a decent enough for, especially for something like maybe a mental health visit where you're just having a conversation and you don't have to really see the details of a lesion or anything like that. If you're trying to see some high quality images, you're probably going to need a faster bandwidth than that. And you'll want a hard connection, not like a data connection, if at all possible. And these are all things that your IT team would be working on. And then again, depending on what you're doing, you may just need video conferencing software. And again, you want to make sure that that's HIPAA compliant. Of course, you'll need some sort of device. So a desktop or a laptop, a tablet, a camera, speakers, all of those things. There's a lot of different peripheral devices that the need will be determined on what type of service you're trying to provide. Back in the day, when telemedicine first started, everybody who was doing telemedicine had these telemedicine carts. So it was this big cart and it had all these pieces and parts to it, and they were very expensive. And you still do see those in hospitals for certain services. They may have a cart, but those are very expensive, and so they're typically not really necessary anymore. Technology's come a long way. And then if you're doing remote patient monitoring, what equipment do you need, depending on what type of monitoring you're doing. And so of course, what you need will be dependent upon your budget, what services you're providing, and then what are your organization's barriers, and what are the patient's resources, and what are their barriers, and how to make sure that you can connect with the patients you're trying to connect with. When you're considering what vendor to go with, there's a lot of different options. Some of them are more expensive than others. Some of them are easier to use than others. You want to make sure that what you're picking is compatible with any software and hardware that you already have, and can integrate in some way into your electronic health record at whatever level that you need for the service you're providing. And then be careful of the cost. Sometimes they'll quote you a particular cost, but that may be the one-time fee, but then there's a monthly fee or an annual fee on top of that. Or it may be you get this piece for this amount, but then if you want these other pieces, you have to pay additional fees to get the bells and whistles. So be careful about how the costs are quoted. And then you'll want to, I actually recommend that you test it with someone on the other end as if they are a patient. And the less tech savvy person you have on the other end, the better, because you can really see if you get a patient on the other end who's not super tech savvy, how easy is it going to be for them to use, and what's that patient experience look like? Is it cumbersome for them? Are there a lot of buttons to click? Is it very confusing? Those sorts of things. And then, you know, from the provider side, is it hard for the provider to use? Because if the provider is frustrated, no one's going to have a good visit. And then, of course, make sure that it meets your regulatory requirements, it's HIPAA compliant, you can document in the software, or it does what you need for documentation purposes as well. So once you've got your equipment, you're all set up, you'll need to obviously inform your patients that this service exists. So offer it to the patients who would benefit the most. So, I mean, you can advertise it, you can social media advertising channels, printed information, put flyers, all of the things that you would do to market any kind of service. But when you have a patient come in who could really benefit from it, maybe they have difficulty coming into the clinic, those sorts of things, offer it to those patients and see if they're interested. So, you know, next visit, we really don't need you to come into the office for, you know, it's a checkup, it's a check-in, those sorts of things. You have blood work, and the next visit, we're just going over your blood work. Can we do that virtually? And see if you can really help those patients limit their time off of work and travel back and forth and all of those sorts of things. And then just to note that those virtual check-ins and e-visits that we mentioned earlier, where the patient makes a phone call or the patient initiates a conversation through the portal, those do in the regulation have to be patient initiated. So you can't call the patient and say, hey, I want to do a check-in with you and see how you're doing, and then bill for that. That's not allowed. The patient has to initiate, but you can let the patient know that this service exists. So you can, you know, again, flyer or provide them education, let them know, hey, if you ever have a question and you're not sure if you need to come in, or you think you need a change in your medication, those sorts of things, you don't have to come in for a full visit. You can contact us this way. So you can provide that information to the patients. So once you are ready to conduct your first visit, prior to the visit, you'll want to have some clinical staff go ahead and reach out to the patient ahead of time. And do all of those things they would do in the front office, right? So collecting their information, their consent, doing their HIPAA advisory, collecting their history, their medications, all of those things you would do, like when they walk into the waiting room and they're filling out all those forms, and the nurse might collect all this basic historical information. Do all of that ahead of time, and save yourself a lot of time. And then it's really important, especially before the very first visit with a particular patient, to walk them through what that telehealth visit is going to look like. Explain to them you're going to get an email, or you're going to get a text message, or whatever the process is. and you'll click this link, you'll get it at this time, and you'll connect to the provider, all of those sorts of things, and walk them through how it works so that you're hopefully saving time when they actually connect with that provider. They don't have to spend a whole lot of time trying to find the patient because the patient couldn't find the link, right? So hopefully, all of that's addressed ahead of time, but still with that very first visit with the patient, schedule extra time just in case, because it's a lot of times there's technical issues. They can't find the link. It doesn't work. They've got this, they've got that. They don't know where the camera is or whatever the case may be. And so the very first visit, you do tend to have some technical issues. So schedule a little bit extra time so that the provider's not running late on their next telehealth visit because they're still with the patient before. And then now you have a big scheduling issue and your patients are frustrated. While the clinical staff is doing that part and making sure that the patient knows what's going to happen and they're getting all the information, from the provider side, you want to make sure that you review the information in advance, look at the medical record, look at whatever the nurse has collected, all of those things, so you know the reason for the visit and why you're going in and the patient's history and what questions to ask and those sorts of things. Make sure that you have established a private, secure, and quiet location to conduct the visit. Any kind of movement in the background, distractions, background noise, all of those things can be really distracting for patients and makes a video visit really hard. Ensure that your equipment is connected and working properly. Double check your background and your position and related to the camera. You don't want to be really close. You don't want to be really far. I heard a provider talking about how he had to change his lighting because he realized that with his receding hairline, he was having a glare off of his forehead that was very distracting for the patient. So he had to adjust for that. So things like that, check and make sure how you look on the camera to the patient. And then wear what you would wear during an in-person visit, right? So if you wear a professional attire, if you wear a lab coat, maybe even your badge, whatever, when you get in front of that patient, you want them to feel secure and confident in your abilities to take care of them the same as you would in person. And especially for patients who may be hesitant to use telemedicine, you want to do as much as you can to put them at ease. So when you start the visit, introduce yourself and anyone else in the room, who they are, what they do, any kind of introduction, again, you would normally do in an in-person visit. And you want to verify the patient's identity. A lot of people ask the patient to hold their driver's license up to the camera so that they can verify that that's that patient. And then you'll need to document the method of connection. So if you're doing a phone visit, if you're doing a audio-visual visit, all of those things, you need to document how you're connected to the patient and any other people who are involved and where they are physically located. So if the patient is at home, we're connected via audio video, and their spouse is with them, and I have so and so in the room with me, that sort of thing. You'll need to document all of those things. Encourage the patient to take the visit in a secure and private location, and then go through your telehealth consent with the patient and document that in the medical record. That's very important that you document that you have that consent from the patient. Limit and eliminate, if possible, all the distractions and the background noise, and allow the patient to play an active role in the experience. So as much as possible, you can't, feel the patient's throat for swelling or, palpitate their abdomen for pain and those sorts of things. And, but they can, and you can ask them, press here, does that hurt? You can ask the patient to stand and walk so that you can see their gait, those sorts of things. So as much as you can, have the patient engage in the experience because they feel more comfortable and they learn from that. And they become better stewards of their own health through doing that as well. express empathy and verbalize understanding by actively listening. Again, it's a little bit harder to see people on the screen, especially the patient may be on like a phone, like a cell phone. And so the screen may be small, and so you may have to be a little bit more expressive and use your words more than you would in an in-person visit. You can nod and they can see that, but they may not be able to see it as clearly in a video. So you may want to nod a little bit bigger and use your words and, you know, those sorts of things. Again, don't record the session. Protect the patient's privacy as you would in an in-person visit, ask people to leave the room, etc. And then direct the person to inpatient care, in-person care for further eval or testing if it's medically necessary. Don't feel like you have to finish a visit or you have to do treatment virtually if it's not what's best for the patient. And then you need to document in the medical record at the same level as if it was an in-person visit. So anything you would document in person, document via telemedicine. And so you've done your visit, you've documented, and so now it's time to bill and get reimbursed. And again, the caveat here is that all of this guidance in this section are the rules under normal circumstances. And then some of these have been waived or changed during COVID-19. And I have a separate section that'll talk about the COVID-19 changes. So high level will hit Medicare, Medicaid, and commercial payers a little bit. And so for Medicare, they consider the geography, the patient setting, the technology connection, the provider type, and the service type in determining if a service will be paid. Medicaid typically looks at the patient setting, the technology, the provider type, the service type, and then commercial payers are governed by parity law in some cases, and that is the case in Louisiana, and we'll talk about what parity law is. And then there are some exclusions to that. Some commercial payers do actually follow Medicare or Medicaid, so that's something you'll have to check what they follow. So for Medicare, geographically, the patient must be in an eligible area. So eligible areas are health professional shortage areas and rural areas, and they define rural as a county, or in our case, a parish, that's not included in a metropolitan statistical area. And they actually have a website where you can go and you can plug in your address of where the patient will be and determine if that's considered an eligible area for a telehealth visit. And they also have to be in an eligible facility. So they have to be in an office, hospital, clinic, skilled nursing facility, mental health center, or a dialysis center. And again, those facilities have to be in the appropriate geographical area in order to be reimbursable. There's a specific list of providers who can actually deliver services via telehealth. Physicians, NPs, PAs, midwives, CNS, CRNA, clinical psychologists, social workers, and registered dietitians are nutrition professionals. And they only reimburse very specific codes. And there's a link there that will give you the actual list of codes that are reimbursed. When billing, you would use the appropriate code from the list. And then you would note 02 as the place of service on the billing form, and that indicates that it's a telemedicine visit. They do reimburse the originating site where the patient is, because again, they have to be in a facility. And so you bill with this Q3014 HCPCS code, and that facility is reimbursed at about $26. And an important thing to note, this is the list of practitioners that Medicare will reimburse. However, the licensing board for any of these particular professions can allow or not allow a particular practitioner type to deliver services via telehealth. So you want to make sure that if you are a specialty that's trying to deliver telehealth, that your licensing board actually allows you to do so. And some of them may allow for certain services and not others. So that's something you want to make sure that you're clear with your licensing board what is allowed. Additional information from Medicare. Again, Medicare only considers telehealth interactive live audio video telecommunications. They do not reimburse rural health clinics and federally qualified health centers to serve as the distance site and provide telehealth services. And then they do reimburse covered telehealth services equivalent to the provider rate if they were at a facility. And that facility rate, if you're not familiar, there's an office rate and a facility rate. So if you're an independent practitioner in an office, the reimbursement rate is slightly higher. In some cases, just a couple of dollars. In order to kind of help cover overhead, versus the facility rate is what the provider gets reimbursed if they're in another facility that's billing their own facility fee. And so it's a slightly lower reimbursement to the provider directly because they don't have an overhead cost. So that's what I mean by provider facility rate. Again, because Medicare only considers live audio video as telehealth, they have these other virtual services, the virtual check-ins, and the e-visits. They cannot be utilized for a problem that a patient was seen in person for within the last 7 days or within the next 7 days. So if a patient has a visit and then a couple of days later they call you with a problem, you can't bill for that virtual check-in. Or if they call you and you say, yeah, you need to come in, then you bill for the in-person visit, but you do not bill for that phone call, the check-in. They have specific codes associated with them, and there's a lower reimbursement rate than a full visit because, again, it's just a couple of minutes, and they're not considered telehealth. And that also means that they're not subject to the same restrictions and regulations and billing guidelines. So you would just bill the code. You don't have to put a O2 place of service or anything like that. Store and forward is not covered by Medicare. There's a couple of exceptions. In Alaska and Hawaii, they're doing some demonstration projects, so there's some reimbursement for them, but that doesn't apply to us. Remote patient monitoring is the general term. Medicare, because they like to use different terminology sometimes, calls it remote physiologic monitoring. It can only be utilized with an established patient. There's specific codes for, there's a code for setup and education. There's a code for 30 days of transmission, and then there's a separate code for the staff or the provider to communicate with the patient about whatever data they're receiving. It's not limited to specific providers, and it's not limited based on the patient's condition. So it's not, only allowed for specific conditions or anything like that. Unlike chronic care management, the patient has to have 2 or more chronic conditions. That's not the case with remote patient monitoring. And the chronic care management, the codes there are based on the amount of time spent managing the patient. And the chronic care management is limited to these specific providers: physicians, nurse midwives, clinical nurse specialists, nurse practitioners, and physician assistants. So that's Medicare. Louisiana Medicaid is a little bit looser. There's no geographic restriction. So the patient and the provider can be in any location, but they do not pay originating site fees. So if the patient is in a clinic and connects via telemedicine to, say, a specialist, the clinic where the patient is doesn't get paid an originating site fee for that visit. Only the specialist on the other end can bill for that telemedicine visit. The Medicaid does not limit the types of providers who can utilize telehealth and bill. Again, verify with your licensing board if there's any restrictions from that end. And unlike Medicare, for Medicaid, RHCs and FQHCs can provide telehealth services as the distance site. Medicaid has referred to the CPT manual Appendix P as the list of services that they reimburse via telehealth. This may change. There was recently, because this is not a hard and fast rule, it's been published mostly as this is our general reference. If we cover it in person and it's in Appendix P, we reimburse for it. But there may be services that if you ask, particularly if you ask the managed care organizations rather than traditional Medicaid, a lot of patients are with an MCO, a managed care organization. And so if you ask one of those providers, they may cover services via telehealth that are not on this Appendix P. So that is an important thing to ask. But there was recent legislation in this past legislative session that required Medicaid to publish a specific list of all of the services that are covered via telehealth. And so that list is pending and hopefully will be published soon. You would utilize, when you're billing, you utilize the same CPT code as an in-person. Again, the place of service of O2 indicating telehealth. Medicaid also requests a 95 modifier be added. They're reimbursed at the same rate as an in-person visit, but they only reimburse real-time interactive audio and video communications for those CPT codes. They don't cover store and forward. They do have a rule that was recently released where they will reimburse the installation fee and monthly maintenance fee for some specific remote patient monitoring. It does need to be pre-approved and there's a lot of caveats to it. So if that was something you're considering doing, you would need to reach out to to Medicaid and the MCOs and make sure that you meet all of the requirements to be reimbursed for those fees. So for commercial payers, some states, including Louisiana, have a parity law. And so in general, what a parity law means is that the commercial payers are mandated to reimburse for telehealth services the same as they would reimburse for in-person services. So the Louisiana parity law actually says that, to paraphrase, if the commercial payer pays for a service in person, they cannot deny it just because it was delivered via telehealth, and they cannot reimburse less than 75% of the reasonable and customary amount of payment that they would give for an in-person visit. So that's what the parity law states in Louisiana. There is an exception to this rule. There are certain plans that are called ERISA plans, the Employer Retirement Income Security Act. And so these are self-funded plans. So an organization self-funds their own insurance for their employees. And so they are not subject to the state regulations of the normal commercial payers. So they're not held to that standard. So a self-funded employer plan does not necessarily have to cover telehealth visits. So all of those are the standard rules in normal times. But with the public health emergency that's ongoing, there have been a significant number of changes to telehealth regulations and guidelines that continue to be extended as the public health emergency is extended. So along with those changes, there's been an incredible increase in utilization of telehealth. A recent publication that I saw said that internal CMS analysis found that prior to the public health emergency, only 14,000 beneficiaries used telehealth services in a given week. But during the public health emergency, just between mid-March and early July, when the data was analyzed, 10.1 million beneficiaries had utilized a telehealth service. So, and I mean, I've heard providers talking about having, you know, 400% or more increases in their telehealth utilization for those that had it before the public health emergency. And then a lot of providers never did telehealth before and are doing it now. So it's been a huge change in the landscape. And there's ongoing regulatory changes and legislative proposal to make permanent some of the changes that were put in place for the public health emergency. So we're continuing to watch those. At the beginning, in the March to May and June timeframe in particular, the rules were changing literally every day. And so there was constant updates from both the federal side and the state side around regulations and billing and all of those things. And so those have pretty much stabilized at this point. And now most of the information that's coming out is these proposed rules about making some of these changes permanent. So we'll be looking out for any of those changes. One of the regulatory changes was the federal government announced that they are loosening restrictions to allow for telehealth practice across state lines. However, providers are still bound by state regulations. And again, the license requirements are really regulated by the state. So although having the federal government support, I think, did help, some states implemented emergency licenses or waived their license requirements when the federal government came out with this statement that they were allowing telehealth across state lines. But some states did not necessarily change their licensing requirements because the state rules still apply. In terms of HIPAA, this was a huge change in the regulation because, as previously mentioned, in normal circumstances, HIPAA still applies. And so you have to use a HIPAA compliant software in order to connect with a patient. And so effective in mid-March, the Office of Civil Rights put out a notice that they are not enforcing this requirement and they are waiving any penalties. So they're not going to check on it and they're not going to punish you if you, in good faith, utilize everyday communication technologies with providers who are not HIPAA compliant, with whom you do not have a business associate agreement. So this allowed providers to utilize software such as FaceTime and Skype and other free softwares that were easily available to them throughout the public health emergency. And so that opened the door and allowed providers to be able to start doing telemedicine without having to do research and buy expensive software and all of those things. They could just jump in and do FaceTime. They did put the caveat of, you know, if you can use HIPAA compliant technology and you have it, please do. But if it's not available, you can use another technology, but make a good faith effort to have as much security and privacy as possible. And they did, I'm guessing some people used some of these tools because they did specifically come out later and say public facing communication apps cannot be used. So Facebook Live, Twitch, and TikTok should not be used for telemedicine visits. And I'm guessing that someone actually used these, and that's why they specifically listed them as not being acceptable under these Office of Civil Rights waivers. For Medicare reimbursement, they have loosened the restrictions of who can actually provide telehealth services and be reimbursed. Any provider who can independently bill for their services can utilize telehealth. So that's allowed for practitioners such as occupational therapists, physical therapists, speech therapists, those types of professionals who can bill, who normally can't do telehealth, they can do telehealth now. They are allowing rural health clinics and federally qualified health centers to provide telehealth distance site services, which is a huge change for those providers. There's a specific code for them, and they get reimbursed at this $92 rate. And the Medicare restrictions on the originating site are temporarily lifted. So the patient and provider can be in any location. They're no longer bound by that geographic restriction, and they're no longer bound by having to be in a particular facility. So that it was also a really significant change. And I believe that was the very first change that they made at Medicare. Over the past few months, they have added approximately 80 services to the telehealth list on a temporary basis, including some evaluation and management codes and some emergency department codes. They have identified particular services that can be delivered via audio only connection. So some standard codes that if a video connection is not available, you can do it via audio only. And of course that would need to be documented in the medical record if you were to do that. And then they also added some codes that are specifically telephone visits. The CPT descriptor actually is for a telephone visit. So those have been temporarily added. And then there are several services that we mentioned where an existing relationship must exist. So like an e-visit and a virtual check-in, the patient has to be an established patient. During the public health emergency, CMS is not enforcing this rule and they're not auditing. So patients who are new patients who've never seen a particular provider can initiate a visit with a new provider. In Louisiana, Medicaid, the state medical officer actually issued an order directing providers to utilize telehealth in place of an in-person visit as appropriate. So they actually required providers to do telehealth if they could, if they had the capability, if their patients had the capability, and they could deliver quality standard of care. All providers in Louisiana were directed to utilize telehealth, which was a significant announcement from the state medical officer. They are allowing all telemedicine services to be conducted via audio only connection if an audio video connection is not immediately available. And then in addition to the regular CPT Appendix P codes, they also added a couple of teledentistry codes, the EPSDT preventative services for patients who are 24 months of age or older, some of those well child care visits. So those are the big changes with COVID-19. And again, we're in the process of they're trying to figure out which things are going to stay in place, which things are going to sunset. Right now, all of these things are in place until the end of the public health emergency. So as the public health emergency gets extended, these rules also get extended. And so until they're they're either sunsetted actively or made permanent actively, they are just in place until the public health emergency is declared completed or the emergency declaration expires and is not renewed. So some resources if you have questions, if you need additional information about telemedicine, the TxLaw Telehealth Resource Center is the kind of the primary contact for information about telemedicine in Texas and Louisiana. It's a federally funded program that's designed to provide free technical assistance and resources to telehealth programs. And so the TxLaw is a partnership between Texas Tech and Well Ahead Louisiana, where I work. And so through that partnership, I serve as the Louisiana site coordinator. And so by technical assistance, basically what we mean is questions, right? Can I do this? Can I do that? Can I get paid for this? You know, what can I do? Those sorts of things. And TxLaw is one of 12 regional telehealth resource centers. This is the map of all the ones in the US. And then there's also 2 national telehealth resource centers. There's a Center for Connected Health Policy that tracks all of the telehealth policy across the country. and then the Telehealth Technology Resource Center, TTAC, which is the resource for software and hardware related to telemedicine. And they have toolkits and guides and all of those things on their website for selecting equipment. All of the regional TRCs are partnered together in the National Consortium of Telehealth Resource Centers. Their website is there. Again, TextLaw is for Louisiana and Texas. The website is there. Connected Health Policy and Telehealth Technology Resource Center. I've included there the link to the list of CMS telehealth services, as well as the link to the Louisiana Medicaid provider manuals. And then for COVID-19 specific resources, the Well Ahead website is a good resource because we've kind of collected a lot of the information from a lot of different sources and combined them into one web page to make it a little bit easier. And it also includes a list of several telemedicine FAQs, which have the general rules as well as what are the COVID-19 changes. And then these are the primary pages where the CMS and Louisiana Medicaid COVID-19 information is listed. So that is all of the information I have. I know it was a lot, and I've talked for quite a long time. But if you have any questions, please feel free. I think that you guys should be able to unmute yourselves and ask any questions that you might have.
I'm part of a student club that is starting telemedicine, not for any kind of, like, nobody's going to get billed. It's been a free clinic that students offer for a long time. But I was wondering if there was, like, not even a presentation, but maybe just like an infographic about what you had called oh God, I just lost the word, but like manners, etiquette, yes, etiquette is the word I was looking for. Yeah, is there like a main resource that you would recommend about etiquette?
I can see if I can find like one resource for you, because a lot of the information is still evolving, I think, as more people are coming on and developing best practices. But a lot of the information that I've learned has been kind of piecemealing other people's presentations where they talk about their experiences. But I will look for if I can find some sort of like one pager or something that has that information on it.
Thank you.
And what was your name? I'm sorry.
I'm Nora.
Okay, I want to make sure I'll send it to Robin so she can send it to everyone so everyone can have. I want to make sure that I know the person who asked.
Okay, I have more questions.
Sure.
So when you've described having like everybody on board, how much does that apply to having like multiple people on one video call or one phone call? Are there any like restrictions or like best practices in terms of having like a student doctor and a doctor, or the nurse and the doctor, something like that?
Yeah, so that's there's no restrictions on that. The kind of the rule would be if you're billing, then the person delivering the care needs to be qualified to deliver services for the payer, right? So like Medicare, the physician would need to be the one delivering the care, right? The nurse can also be in the room and support, but for billing purposes, the provider has to be the one actually delivering care. And then from kind of a regulatory perspective, you would just need to make sure that anyone in the room is introduced to the patient and who they are and what their role is. And so you don't want to have anyone in the room that the patient's not aware of, that person is there and can hear their information. And it's usually a good idea to kind of make a sweep of the room with your camera to show the patient who's in the room or that there's no one else in the room.
Thank you.
No problem. All right, well, I'm not hearing any other questions. So I'm just gonna put this up. This is contact information. General telehealth questions can go to the Telehealth Resource Center. That's the website for, that's the email address rather for the Textlaw Telehealth Resource Center. There's a phone number there. Or you're welcome to email me directly, and that's my direct email address there. So any questions, anything that you might need, if someone else asks you a question about telemedicine, you are welcome to provide them with my information, and I will be happy to assist them with whatever telemedicine questions that they might have.
Thank you.
Thank you so much for your presentation.
Yes.
Thank you guys.
Thank you.
Thank you.
Y'all have a good night.